Good day, everyone. So let's proceed with the other conditions that may be a focus of clinical conditions. So this covers the other condition and problems that may be a focus to a clinical attention or that may otherwise affect the diagnosis, course, prognosis, or treatment of patients' mental disorder. So these conditions are presented with their corresponding codes from ICD-9-CM, or usually called as V codes, and ICD-10-CM that usually called as Z codes. So conditions and problems in this discussion can also serve as information for that can be included in the medical record of a person if it is a reason for the current visit or helps that needs to test, procedure, or treatment. And more importantly, conditions and problems mentioned in this discussion is not mental disorders. The inclusion of these conditions and problems in the DSM-5 meant to draw attention to the scope of additional issues that may be encountered in a routine clinical practice. So, let's proceed with the topic outline. First, we have the problems related to family upbringing. Second, other problems related to primary support group. Next, child maltreatment and neglect problems, adult maltreatment and neglect problems, educational and occupational problems, housing and economic problems, other problems related to the social environment, problems related to crime or interaction with the legal system, other health service encounters for counseling and medical advice, other circumstances of personal history, problems related to access to medical and other health care, non-adherence to medical treatment. Yes, so that's the topic outline. For the intended learning outcomes, at the end of the discussion, we will learn the different conditions and problems that may be a focus of the clinical conditions. Next. All right. So, problems related to family upbringing. First, the parent-child relational problems. So, parent, this term refers to the one of the child's primary caregiver, which may be the biological, adoptive, or foster parent, or any relative such as grandparents, who are fulfilling the parental role for the child. So this category is used when the main focus of the clinical attention is to address the quality of the parent-child relationships, or when the quality of the parent-child relationship is affecting the mental state of a child. So typically, this parent-child relationship problem is associated with impaired functioning in the behavioral, cognitive, or affective domains. For example, the behavioral problems. This includes inadequate parental control, supervision, and involvement with the child, or parental overprotection, excessive parental pressure, arguments that escalate to threats of physical violence, and avoidance without resolutions of the problems. Next, another example is cognitive problems. This includes negative attributions of the other's intentions, hostility toward or scapegoating of the other, and unwarranted feelings of estrangement. And lastly, or last example is affective problems, and this may include the feeling of sadness, apathy, or anger about the other individual in the relationship. Next, second, the sibling relational problem. So this category is used when the focus of the clinical attention is a pattern of interaction among the siblings that is associated with significant impairment in individual or family functioning, or with development of symptoms in a one or more of the siblings. So this category can be used either for the children or adults if the focus is on the siblings relationship. And siblings in this category can be full, half, step, foster, and adopted siblings. Next, number three, the upbringing away from parents. So The main focus of this category is the clinical attention pertains to the issues regarding a child being raised away from the parents or when these separate upbringings affects the child's mental state. So the child can be under state custody and placed in the kin care or foster care. So the child can also be the one who is living in a non-parental relative's home or with friends but who's out of home placement is not mandated or sanctioned by the courts. And in this category, the problems related to the child living in the orphanage are also included. However, in this category, it excludes the issues related to the children boarding to school. Next, number 4, the child affected by parental relationship distress. So this category is focused on the negative effects of the parental relationship discord such as high levels of conflict, distress or disparagement on a child in the family, including effect on the child's mental or other medical disorders. Okay, next we have here the other problems related to primary support group. So this category is used when the major focus is to address the quality of the intimate either of the spouse or partner relationship. Partners can be of the same or different genders. However, this category excludes clinical encounters for mental health services, for spousal or partner abuse problems and sex counseling. So typically, this category of relationship distress is associated with the impaired functioning to the behavioral, cognitive, and affective domains. Example for the behavioral problems, so this includes conflict resolution difficulty, withdrawal, and other involvement. For the cognitive problems, example is this can manifest the chronic negative attributions of the other's intentions or dismissals for the partner's positive behavior. And for the affective problems, this include chronic sadness, apathy, or anger about the other partner. Next, number 2. So, disruption of family by separation or divorce. So, this category is used when partners in an intimate adult couple are living apart due to relationship problems or are in the process of divorce. Number 3, high express emotion level within family. So this category is used when the focus of the clinical attention is the family's high level of expressed emotion. And number 4, uncomplicated bereavement. So this category is used when the focus of the clinical attention is a normal reaction to the death of a loved one. As part of their reaction to such a loss, some grieving individuals present with symptoms characteristic of a major depressive episode, for example, feelings of sadness and associated symptoms such as insomnia, poor appetite, and weight loss. And wait. So let's go back with the number 4. So the bereaved individual typically regards the depressed mood as normal, although the individual may seek professional help for relief of associated symptoms such as insomnia or anorexia. So the duration and expression of normal bereavement vary considerably among different cultural groups. Further guidance in distinguishing grief from a major depressive episode is provided in the criteria for major depressive episode. 5. Abuse and neglect. Maltreatment by a family member such as caregiver, intimate adult partner, or by a non-relative can be the area of current clinical focus, or such maltreatment can be an important factor in the assessment and treatment of patients with mental or other medical disorders. So, here number 5, having a past history of abuse or neglect can influence diagnosis and treatment response in a number of mental disorders and may also be noted along with the diagnosis. So next, let's proceed here with the coding note for ICD-IOCM abuse and neglect conditions for T codes only. The 7 characters should be coded as follows. So for the A, the initial encounter, used while the patient is receiving active treatment for the condition. Example, the surgical treatment, the emergency department encounter, evaluation and treatment by a new clinician. For the D, or the subsequent encounter. So used for encounters after the patient has received active treatment for the condition and when he or she is receiving routine care for the condition during the healing or recovery phase, such as cast change or removal of external or internal fixation device, medication adjustment, other aftercare, and follow-up visits. All right, next, let's have here the child maltreatment and neglect problems. Number one, the child physical abuse. So this is a non-accidental physical injury to a child ranging from minor bruises to severe fractures or death. So occurring as a result of punching, beating, kicking, biting, shaking, throwing, stabbing, choking, or hitting with a hand, stick, strap, or other object, burning, or any other method that is inflicted by a parent, caregiver, or other individual who has responsibility for the child. So, such injury is considered abuse regardless of whether the caregiver intended to hurt the child. Physical discipline such as spanking or paddling is not considered abuse as long as it is reasonable and causes no bodily injury to the child. Okay, next. The child physical abuse confirmed. We have here the initial encounters, subsequent encounter. Next, for the child physical abuse suspected, initial encounter and subsequent encounter. For the other circumstances related to child physical abuse, first, we have here the encounter for mental health services for victim of child abuse by parent. Next, encounter for mental health services for victim of non-parental child abuse. Next, personal history or past history of physical abuse in childhood. Another one is encounter for mental health services for perpetrator of parental child abuse. And lastly, the encounter for mental health services for perpetrator of non-parental child abuse. Next, second here we have the child sexual abuse. So this encompasses any sexual act involving a child that is intended to provide sexual gratification to a parent, caregiver, or other individual who has responsibility for the child. So sexual abuse includes activities such as fondling a child's genitals, penetration, incest, rape, sodomy, and indecent exposure. Sexual abuse, this also includes non-contact exploitation of a child by a parent or caregiver. For example, forcing, tricking, enticing, threatening, or pressuring a child to participate in acts for the sexual gratification of others without direct physical contact between child and abuser. So, we have here child sexual abuse confirmed, initial encounter, subsequent encounter for the child sexual abuse, suspected initial encounter, and subsequent encounter. For the other circumstances related to child sexual abuse, we have the encounter for mental health services for victim of child sexual abuse by parent, Encounter for mental health services for victim of non-parental child sexual abuse, personal history of sexual abuse in childhood. Encounter for mental health services for perpetrator of parental child sexual abuse, and encounter for mental health services for perpetrator of non-parental child sexual abuse. Next. Third, the child neglect. So child neglect is defined as any confirmed or suspected egregious act or omission by a child's parent or other caregiver that deprives the child of basic age appropriate needs. So it encompasses it encompasses abandonment, lack of appropriate supervision, failure to attend to necessary emotional or psychological needs, and failure to provide necessary education, medical care, nourishment, shelter, or clothing. Right, next. So, for the child neglect, suspected, the initial encounter, subsequent encounter, and for the other circumstances related to child neglect, encounter for mental health services for victim of child neglect by parent, encounter for mental health services for victim of non-parental child neglect, personal history of neglect in childhood, encounter for mental health services for perpetrator of parental child neglect, and encounter for mental health services for perpetrator of non-parental child neglect. Next, let's have the number 4, or the child psychological abuse. So it is a non-accidental verbal or symbolic act by a child's parent or caregiver that result or have reasonable potential to result in significant psychological harm to the child. However, physical and sexual abusive acts are not included in this category. So examples of psychological abuse of a child include berating, disparaging or humiliating the child, threatening the child, harming, abandoning, or indicating that the alleged offender will harm or abandon people or things that the child cares about, or confining the child, such as tying a child's arm or legs together or binding a child to furniture or another object, or confining a child to a small enclosed area, for example, closet. Egregious scapegoating of the child, coercing the child to inflict pain on himself or herself, and disciplining the child excessively, for example, at an extremely high frequency or duration, even if not at a level of physical abuse, through physical or non-physical means. So next, let's proceed with the adults maltreatment and neglect problems. For the number 1, the spouse or partner violence physical. So this category should be used when non-accidental acts of physical force that result or have reasonable potential to result in physical harm to an intimate partner or that evoke significant fear in the partner that have occurred during the past year. So, non-accidental acts of physical force include shoving, slapping, hair pulling, pinching, restraining, shaking, throwing, biting, kicking, hitting with a fist or an object, burning, poisoning, applying force to the throat, cutting off the air supply, holding the head underwater, and using a weapon. So, acts for the purpose of physically protecting oneself or one's partner are excluded. Number 2, we have the spouse or partner violence sexual. So this category should be used when forced or coerced sexual acts with an intimate partner have occurred during the past year. So sexual violence may involve the use of physical force or psychological coercion to compel the partner to engage in a sexual act against his or her will whether or not the act is completed. It also included in this category are sexual acts with an intimate partner who is unable to consent. Next, number 3, the spouse or partner neglect. So, partner neglect is any egregious act or omission in the past year by one partner that deprives a dependent partner of basic needs and thereby results or has reasonable potential to result in physical or psychological harm to the dependent partner. So, this category is used in the context of relationships in which one partner is extremely dependent on the other partner for care or for assistance in navigating ordinarily daily activities. For example, a partner who is incapable of self care owing to substantial physical, psychological, intellectual, or cultural limitations such as inability to communicate with others and manage everyday activities due to living in a foreign culture. So, next, number 4, the spouse or partner abuse psychological. So, this partner psychological abuse encompasses non-accidental verbal or symbolic acts by one partner that result or have reasonable potential to result in significant harm to the other partner. So, this category should be used when such psychological abuse has occurred during the past year. So, the acts of psychological abuse include berating or humiliating the victim, interrogating the victim, restricting the victim's ability to come and go freely, obstructing the victim's access to assistance such as law enforcement, legal, protective, or medical resources, threatening the victim with physical harm or sexual assault, harming or threatening to harm people or things that the victim cares about, unwarranted restriction of the victim's access to or use of economic resources, isolating the victim from family, friends, or social support resources, stalking the victim, and trying to make the victim think that he or she is crazy. So next, we have here the adult abuse by non-spouse or non-partner. These categories should be used when an adult has been abused by another adult who is not an intimate partner. Such maltreatment may involve acts of physical, sexual, or emotional abuse. So, examples of adult abuse include non-accidental acts of physical force such as pushing, shoving, scratching, slapping, throwing something that could hurt, punching, biting that have resulted or have reasonable potential to result in physical harm or have caused significant fear, force or coerce sexual acts, and verbal or symbolic acts with the potential to cause psychological harm, such as berating or humiliating the person, interrogating the person, restricting the person's ability to come and go freely, obstructing the person's access to assistance, threatening the person, harming or threatening to harm people or things that the person cares about, restricting the person's access to or use of economic resources, isolating the person from family, friends, or social support resources, stalking the person, trying to make the person think that he or she is crazy. So the acts for the purpose of physically protecting oneself or the other person are excluded. So next, we have the educational and occupational problems. Number 1, we have the academic or educational problem. So this category should be used when an academic or educational problem is the focus of clinical attention. So in this, the problems to be considered include illiteracy or low-level literacy, lack of lack of access to schooling owing to unavailability or unattainability, problems with academic performance, for example, failing school examinations, receiving failing marks or grades, or underachievement, discord with teachers, school staff, or other students, and any problems related to education or literacy. Next, the occupational problems. Number one, the problem related to current military deployment status. So this category should be used when an occupational problem directly related to an individual's military deployment status is the focus of clinical attention or has an impact on an individual's diagnosis, treatment, or prognosis. So the psychological reactions to deployment are not included in this category. Such reactions would be better captured as an adjustment disorder or another mental disorder. Number two, other problem related to employment. So this category should be used when an occupational problem is the focus of clinical attention or has an impact on the individual's treatment or prognosis. So here, number two, the areas to be considered include problems with employment or in the work environment, including unemployment, recent change of job, threat of job loss, job dissatisfaction, stressful work schedule, uncertainty about career choices, sexual harassment on the job, other discord with boss, supervisor, coworkers, or others in the work environment, uncongenial or hostile work environments, other psychosocial stressors related to work, and any other problems related to employment or occupation. So next, let's have the housing and economic problems. Number one here is the homelessness. This category should be used when lack of a regular dwelling or living quarters has an impact on an individual's treatment or prognosis. So an individual is considered to be homeless if his or her primary nighttime residence is a homeless shelter, a warming shelter, a domestic violence shelter, a public space such as tunnel, transportation station, mall, a building not intended for residential use, for example, abandoned structure, unused factory, a cardboard box or cave, or some other ad hoc housing situation. Number two, the inadequate housing. So this category should be used when lack of adequate housing has an impact on an individual's treatment or prognosis. So examples of inadequate housing conditions includes lack of heat in cold temperatures or electricity, infestation by insects or rodents, inadequate plumbing and toilet facilities, overcrowding, lack of adequate sleeping space, and excessive noise. It is important to consider cultural norms before assigning this category. Next, number three, the discord with neighbor, lodger, or landlord. So this category should be used when discord with neighbors, lodgers, or a landlord is a focus of clinical attention or has an impact on the individual's treatment or prognosis. Our number four, problem related to living in a residential institution. So this category should be used when a problem related to living in a residential institution is a focus of clinical attention or has an impact on the individual's statement or prognosis. So the psychological reactions to a change in living situation are not included in this category, and such reactions would be better captured as an adjustment disorder. Next, the economic problems. First, we have the lack of adequate food or safe drinking water. Second, extreme poverty. Number 3, low income. And number 4, insufficient or social insurance or welfare support category. So this category should be used for individuals who meet eligibility criteria for social or welfare support but are not receiving such support, who receive support that is insufficient to address their needs, or who otherwise lack access needed insurance or support programs. So examples include inability to qualify for welfare support owing to lack of proper documentation or evidence of address, inability to obtain adequate health insurance because of age or a pre-existing condition, and denial of support owing to excessively stringent income or other requirements. Next, number 5, for the unspecified housing or economic problem. This category should be used when there is a problem related to housing or economic circumstances other than as specified above. Alright, so let's proceed with the other problems related to the social environment. Number 1 here is the phase of life problem. This category should be used when a problem adjusting to a life cycle transition, a particular developmental phase, is the focus of clinical attention or has an impact on the individual's treatment or prognosis. So examples of such transitions include entering or completing school, leaving parental control, getting married, starting a new career, becoming a parent, adjusting to an empty nest after children leave home, and retiring. Second, we have the problem related to living alone. So this category should be used when a problem associated with living alone is the focus of clinical attention or has an impact on the individual's treatment or prognosis. Examples of such problems include chronic feelings of loneliness, isolation, and lack of structure in carrying out activities of daily living such as a regular meal and sleep schedules, inconsistent performance of home maintenance chores. Next, number 3, we have the acculturation difficulty. So this category should be used when difficulty in adjusting to a new culture such as migration is the focus of clinical attention or has an impact on the individual's treatment or prognosis. Number 4, we have the social exclusion or rejection. So this category should be used when there is an imbalance of social power such that there is recurrent social exclusion or rejection by others. So being targeted by others for verbal abuse and humiliation, and being purposefully excluded from the activities of peers, workmates, or others in one's social environment. So that are the example of the social exclusion or rejection. Next, we have the number 5, the target of perceived adverse discrimination or persecution. So this category should be used when there is perceived or experienced discrimination against or persecution of the individual based on his or her membership or perceived membership in a specific category. So typically, such categories include gender or gender identity, race, ethnicity, religion, sexual orientation, country of origin, political beliefs, disability status, social status, weight, and physical appearance. For number 6, we have the unspecified problem related to social environment. This category should be used when there is a problem related to individual social environment other than as specified above. Alright, next, we have the problems related to crime or interaction with the legal system. First, the victim of crime. Second, the conviction in civil or criminal proceedings without imprisonment. Third, imprisonment or other incarceration. Fourth, problems related to release from prison. And fifth, the problems related to other legal circumstances. Next, let's proceed with the problems related to other psychosocial, personal, and environmental circumstances. First, we have the religious or spiritual problem. This category can be used when the focus of clinical attention is a religious or spiritual problem. Examples include distressing experiences that involve loss or questioning of faith, problems associated with conversion to a new faith, or questioning of spiritual values that may not necessarily be related to an organized church or religious institution. Second, we have the problems related to unwanted pregnancy. Third, we have the problems related to multiparity. Fourth, the discord with social service provider, including probation officer, case manager, or social services worker. Fifth, the victim of terrorism or torture. Sixth, the exposure to disaster, war, or other hostilities. Seventh, the other problem related to psychosocial circumstances. And eighth, the unspecified problem related to unspecified psychosocial circumstances. Okay, next we have the other circumstances of personal history. First, we have the other personal history of psychological trauma. Second, the personal history of self-harm. Third, the personal history of military deployment. Fourth, the other personal risk factors. And fifth, problem related to lifestyle. And this category should be used when a lifestyle problem is a specific focus of treatment. Examples of lifestyle problems include lack of physical exercise, inappropriate diet, high-risk sexual behavior, and poor sleep hygiene. So, a problem that is attributable to a symptom of a mental disorder should not be coded unless that problem is a specific focus of treatment or directly affects the course, prognosis, or treatment of the individual. And in such cases, both the mental disorder and the lifestyle problem should be coded. Sixth, we have the adult. Next, we have the adult antisocial behavior. This category can be used when the focus of clinical attention is adult antisocial behavior that is not due to a mental disorder such as conduct disorder, antisocial personality disorder. Examples include the behavior of some professional thieves, racketeers, or dealers in illegal substances. And seventh, the child or adolescent antisocial behavior. So this category can be used when the focus of clinical attention is antisocial behavior in a child or adolescent that is not due to a mental disorder, for example, intermittent explosive disorder and conduct disorder. Examples include isolated antisocial acts by children or adolescents, not a pattern of antisocial disorder. Next, we have the problems related to access to medical and other healthcare. First, we have the unavailability or inaccessibility of healthcare facilities. And second, we have the unavailability or inaccessibility of other helping agencies. Next, let's have the non-adherence to medical treatment. First, the non-adherence to medical treatment. This category can be used when the focus of clinical attention is non-adherence to an important aspect of treatment for a mental disorder for another medical condition. So the reasons for such non-adherence may include discomfort resulting from treatment such as medication side effects, expense of treatment, personal value judgments, or religious or cultural beliefs about the proposed treatment, age-related debility, and the presence of mental disorder such as schizophrenia and personality disorder. And this category should be used only when the problem is sufficiently severe to warrant independent clinical attention and does not meet diagnostic criteria for psychological factors affecting other medical conditions. Next, we have the overweight or obesity. This category may be used when overweight or obesity is a focus of clinical attention. And third, we have the malingering. The essential feature of malingering is the intentional production of false or grossly exaggerated physical or psychological symptoms motivated by external incentives such as avoiding military duty, avoiding work, obtaining financial compensation, evading criminal prosecution, or obtaining drugs. So, under some circumstances, malingering may represent adaptive behavior, for example, feigning illness while a captive of the enemy during wartime. And malingering is differentiated from conversion disorder and somatic symptom related mental disorders by the intentional production of symptoms and by the obvious external incentives associated with it. And next, we have the malingering should be strongly suspected if any combination of the following is noted. Letter A, the medical legal context of presentation, such as the individual is referred by an attorney to the clinician for examination, or the individual self refers while litigation or criminal charges are pending. Letter B, marked discrepancy between the individual's claimed stress or disability and the objective findings and observations. Letter C, the lack of cooperation during the diagnosis evaluation and in complying with the prescribed treatment regimen. Letter D, the presence of antisocial personality disorder. Malingering differs from factitious disorder in that the motivation for the symptom production in malingering is an external incentive, whereas in factitious disorder, external incentives are absent. Alright, next, let's proceed with the number 4, the wandering associated with a mental disorder. So this category is used for individuals with a mental disorder whose desire to walk about leads to significant clinical management or safety concerns. For example, individuals with major neurocognitive or neurodevelopmental disorders may experience a restless urge to wander that places them at risk for falls and causes them to leave supervised settings without needed accompaniment. So this category includes individuals whose intent is to escape an unwanted housing situation, example, children who are running away from home, patients who no longer wish to remain in the hospital, or those who walk or pace as a result of medication-induced akathisia. So, here in number 4, the coding note is first code associated with mental disorder, example, major neurocognitive disorder, autism spectrum disorder, then code wandering associated with specific mental disorder. Alright, next. Number 5, the borderline intellectual function. Number 5, we have the borderline intellectual functioning. This category can be used when an individual's borderline intellectual functioning is the focus of clinical attention or has an impact on the individual's treatment or prognosis. So, differentiating borderline intellectual functioning and mild intellectual disability, intellectual developmental disorder, requires careful assessment of intellectual and adaptive functions and their discrepancies. So particularly in the presence of co-occurring mental disorders that may affect patients' compliance with standardized testing procedures such as schizophrenia or attention deficit hyperactivity disorder with severe compulsivity. With severe impulsivity. So, for the summary of our report, the conditions and problems in this discussion can also serve as information for that can be included in the medical record of a person if it is a reason for the current visit or help that needs the test, procedure, or treatment. More importantly, conditions and problems mentioned in this discussion are not mental disorders. The inclusion of these conditions and problems in the DSM-5 meant to draw attention to the scope of additional issues that may be encountered in a routine clinical practice. So here are the references, and that could be all, and thank you so much for listening.